The broadcast is now starting. All attendees are in listen-only mode.
Good morning and welcome to this morning's webinar. My name is James Stringer and I'm responsible for the Asia and Pacific regions for Aconia. Apologies, we a minute or two late getting started, just a few little technical issues there. I'm going to be introducing you to Martin Abrahams in a moment, who'll take us through the webinar. Just by way of introduction, this is the first time that we've tried to do by webinar a review of case studies for Lunula. So you probably notice on your screen that we've got pictures that will be being displayed by Harish Mitra in Australia, and Martin is in the UK discussing those. So we'll be reviewing the few case studies that have been sent in for this and having some discussion around those. If you have any questions as you're listening to this, then please do feel free to add questions. You can type your questions in during the webinar, and then at the end I'll come back on and I will read out your questions to Martin and she can give us an answer on those. So without further ado, I'd like to introduce Martin Abrahams. And Martin, here in the UK, Martin was our first ever user of the Lunula system. And prior to that, she was the first user of the pinpoint hot laser many years before that. There's a huge amount of experience, more than anybody here in Europe, in terms of using both the hot laser and the Lunula technologies for the treatment of this condition. We're delighted that Martin actually now works with us as on a clinical consultancy basis to support us and our many users throughout Europe. And now we're delighted she's having the opportunity to work with you there in Australia. So I will at that point pass over to Martin, and bear with us a little bit while we review these case studies. Hopefully the technology will support us here to pull up the pictures. So Martin, over to you.
Thanks, James. Hi, everyone. I would say good morning to it's morning here, but good evening to all of you as well. Okay, I think Harish is going to get a couple of case studies up on the screen in a second, but whilst he's doing that, let me just tell you a little bit more about what I do. So I essentially have two jobs. One is that I'm a podiatrist, I'm the owner of the London Nail Laser Clinic, and we have a few clinics over in the UK, our main clinic being in the centre of London. We only use the Lunula now. We are podiatrists, but we don't really practice a great deal of routine podiatry. When I set up the clinic back in 2009, I did start with the pinpoint foot laser, so an NG YAG 1064 nanometer device. We used it for a few years. It didn't give us the results that we wanted, mainly because it's a really uncomfortable treatment. Personally, I don't like to cause pain, and I hated using it because it was very hot and very uncomfortable and painful for some patients. So with that, you could only treat as much as pain tolerance would allow, and therefore the results that we were getting weren't great. They weren't horrendous, but they weren't great. They were better than pretty much anything else I had used over the years, and I've been a podiatrist now for 22 years. I spent the first 10 years of my career in the National Health Service in the UK before going into private practice. Anyway, in 2012, I came across the Lunula actually before it was launched, or right at the beginning of the launch, and having seen it for about 10 seconds, I thought, okay, yeah, this is one I want to try. And the idea originally was that we would use the Lunula and the pinpoint together, and that lasted about 3 weeks before I stopped using the pinpoint altogether, and we bought our second Lunula, and we now have about 8 of them in clinics around the UK. And as I said, that's pretty much all that we use, and we get some really great results. We probably spent the first few years of using it going through every different type of protocol. The protocol that we were given by the US when we started was one treatment, another one a week later, and another one 3 months later. That stopped very quickly. And we have tried everything from daily treatments to monthly treatments to doubling up treatment time. So instead of 12 minutes per cycle, 24 minutes per cycle, doing various things. And for the last few years, what we have found works the best is 4 treatments, weekly or fortnightly or so, but no longer than 4 weeks in between each of those treatments. And then once we've done the 4 treatments, we review monthly. Now, the monthly reviews are not always in clinic. They might be by photo. It depends on the nails. We take a hands-off approach. And so this is something that we'll discuss when we look at the photos in just a moment, because I've looked at the questionnaires that have been sent to me, and I think that people are over-treating. I think that's one of the issues. So I'll go into that in a little bit more detail in a moment. But essentially, the protocol that we follow is 4 treatments. Unless it's a really, really mild problem, then you might get away with 2 treatments. But generally 4 treatments, a week or 2 apart, no longer than 4 weeks between each treatment, and then monthly reviews to start off with. I tend to find with most patients that after about 4 or 5 months or so, we then go to 6 weeks and then 8 weeks. And then patients who have started off with a severe problem, and I'm purposely not saying the word infection to you, because we don't just treat fungal infections. We essentially have gone into, I'll call it nail rejuvenation now. So anybody who comes into our clinics who are not happy with their nails, we will potentially treat, unless there's a reason not to treat, so often a health reason not to treat, but we'll potentially treat, irrespective of whether they have a fungal infection, because experience has shown us that the 635 nanometer diode, so the red one, actually is a healing beam and is really good for healing any damage, irrespective of cause. So it could be caused by onychomycosis, it could be caused by psoriasis, it could be caused by dropping a brick on the toe, could be caused by wear and tear of shoes, anything, and it tends to improve that. So that's something we can go into in a little while. Harish, do you want to put up the first? I can see you've sort of got it, but maybe click on the first photo. Actually, I just need to work out who that is. So if you pop a photo up, I think we should look at the photos, then the questionnaire, and then I will have a quick discussion. We can have a quick discussion. Okay. Okay, so this is a gentleman, I believe, who the main problems are the first, it's just left foot, the first digit and the third and fourth digits. So if you go to the third and the next photo, if you don't mind, Harish, that's possible. Yeah. Yeah. Okay. This is after. Sorry. Go to the before ones, which are the really thickened ones. Yeah. I think are. No, next one. I think there were more photos. I think there were 6 photos, actually. Okay. No, that's someone else. No, that's someone else. I haven't been sent those ones. All right, we can start with this one if you want, because this actually was, I think, quite an interesting person. So, can you zoom in a little bit at the top there? yeah, so hopefully everyone can see that. So brilliant. The main issue is obviously the third nail. And this gentleman was seen earlier this year in July. And the after photo that you'll see in a second is in October, so not very many months. Throughout that period, this patient had 11 treatments. This is the after one. So whilst the nail doesn't look particularly great here, what I can see is that actually if that nail is debrided, a lot of that white will come off straight away, probably leaving an intact nail underneath and a very clear nail. So when you treat a lot of patients, what you tend to see is some very subtle changes that occur over time. And as I said, this isn't very long. This is really only 3 months. And little nails tend to take much longer than large toenails to actually show us what's going on. But what we're looking at is more the nail bed rather than the nail, because nail is actually just dead tissue. It's not really anything. Once it comes out and covers the nail bed, it follows what happens on the actual nail bed. And in my clinics, we debride very aggressively at first. So we get rid of anything that's damaged, anything that's not stuck down. Obviously, if it's stuck down, you don't try and take it off, because the patient will be screaming at you and there'll be a lot of blood. But debride anything that isn't healthy, essentially. And once you do the Lunula treatment, we tend to find changes happen almost instantly. So not that the nail becomes perfect, it's not a miracle cure or anything like that, but actually the healing process begins fairly quickly. We often see that white that you can see on the screen coming through. That will eventually go. And as I say, if you debride it, it tends to go much faster. It will probably come through for a few more months. But what it's doing essentially is it's protecting what's going on underneath. And you're getting some nice healing going on in the nail bed and in the bottom layers of the nail, which are just starting to form from the matrix of the new nail. So it's very difficult to see on that photo, but actually that is quite a good result, or it would be a good result if we could see a debrided version of that nail. However, I will say that it's had 11 treatments. There shouldn't be any more treatments, Lunula treatments done on that nail, really, unless there happens to be a regression in the nail. The extra treatments that I carry out in clinic are only on nails that when I see them in for a review, it's not even that they've regressed or anything, but it's only if I can see evidence of a live fungal infection. So if I can see that there's patches of yellow or white that when I debride, I crack through the nail and it goes through to the nail bed, in all likelihood there is an infection still there. If it's very crumbly, if the nail is very loose, where it wasn't before, then I might carry out an extra treatment. Any extra treatments carried out after the initial 4 have at least 1 month in between them. So whereas beforehand, within the initial 4 treatments, they are all done, or each treatment is done within a month of the last one. After those 4 treatments, we do the opposite and we do at least a month between them. But we still review pretty much monthly. So we think less is more. We only treat when necessary. And the reason for this is twofold. First of all, the body is healing itself. It's, the Lunula sets it on its way, but the body actually needs to do the work. The Lunula is just, a couple of lights which enable the body to do what it needs to do. So nails of those areas, particularly toes, don't have a great deal of blood supply going down there. We all know, really, feet are the last place where the blood tends to go. So what tends to happen is the Lunula, when it fires, it has 2 beams, which are the violet 405 beam and the red 635 beam. The 405 beam starts to break down the fungus. It helps the body to produce hydrogen peroxide, which is an antiseptic, which is antimicrobial, and so it starts to break down the fungus. The red beam produces nitric oxide, which is a dilator. So it dilates blood vessels, increases the blood supply to the area, and enables the immune system and the increase in blood supply to start healing the area. The more blood you have, the quicker things get regenerated. So in summer, particularly in the UK, we see that nails grow faster when it's warmer out, and in the winter, when it's not warm, nails don't grow so fast. With more blood to the area, everything gets regenerated and the tissues tend to grow a lot better. So when you over-treat, you can only get a certain amount of blood down there. And so the body essentially starts to do the opposite, and it says, you know, I've done this already, I don't need to do it anymore. So it stops being useful. It doesn't do anything negative really, it just stops being useful. Although saying that, we have seen that some over-treating can dry the nails out, just makes them start to be more flaky, less healthy looking, in fact, than they should otherwise be. So less treatment is definitely more in most cases. So Harish, do you want to go on to the next case study? Okay, I don't think I've been sent this one, so I don't have any info on it. So can you, I can see that picture. I don't know when that was. Is there a date on it? If you can make it a bit smaller, can I see if there's a date? And then maybe look at the other picture as well. Okay, so that's, and then if you can just pop the other one up for me. I have seen this. Okay. Right, so that's okay. So 13th of November was the start of treatment for this gentleman. He was given 8 treatments between 13th of November and 10th of January, and then had a review on the 26th of February, where I'm not sure whether he had a treatment or not. I believe he may have done, and then was brought back into clinic on the 9th of May for another 6 treatments. So if you can show up the next photo, Harish, if you don't mind, we should have a photo from July, 23rd of July, I believe. Yeah, that's it. No, that's different. Take that look. Okay, right, 24th. Right. Okay, is that the same? Those are the same nails, which I think have had 17 treatments on them. And again, they don't look particularly debrided. A lot of that looks very superficial on the lesser nails, and actually will probably come off with debridement again, leaving fairly pink nail bed underneath, which you can sort of see through the gaps there. On the large nail, there is a very dark patch, the medial aspect at the distal end. And actually that we see an awful lot. That's really from the increased blood supply, and in the end that tends to fade, leaving a fairly decent nail. Unfortunately, the way that photo's taken, the blood is kind of being squeezed up to the top, so it's really distorting what we should be seeing. When you take photos, if the foot is just flat, so the knee is bent and the foot is flat, you tend to even out, obviously, the blood supply there, rather than getting the white areas around the joints in the toe and then red at the end, because it makes it slightly more difficult to see. But essentially, what I can see is that the nails need to be debrided fairly nicely. You should get a very nice thin layer of nail. They're not thickened nails. They've just got a lot of superficial markings on them, and that really needs to come off. Again, treatment needs to stop, and the body needs to just catch up and look after itself and start healing itself a little bit more. Okay, Harish, if we can move on to, I think there may have been some other photos with this person. Yeah, if you, so those two, so that's obviously an after one. If we could just go to the one to the left of it, that I think must be a before photo. Yeah. Okay. So from here, that doesn't look like a particularly severe case of nail damage at all. If you, thank you, that's right. That's perfect. Okay, so there's some damage on there, and you can see a few little spots of fungus also, it looks on there. But if you now, Harish, go to the after photo, okay, so that looks a lot more problematic. Something has obviously happened between, well, within the 10 months that the patient was seen. I'm not sure, there wasn't a great deal on the questionnaire form, so I don't really know what has happened. And really what we should be seeing is photos pretty much monthly. So if someone comes into clinic for a review or sends photos in, we should be able to look at a series of photos, because then you can pinpoint what's going on and what's happened. If this gentleman, I'm not sure if he was seen between July and September, or really what has happened, but obviously that's not a good result. And what I would do at this point is I would debride the nails, take them right down, see what's going on underneath, and then leave it for a little bit, because sometimes if you overtreat, you then obviously have a problem where the body's not going to respond to any further treatment, and that may well be the case. I would find out what the actual history is of the last few months. So has this patient been on holiday? Have they been wearing steel toe caps? What's been going on? Because there's obviously more damage that's occurred there than before. What's happened with the patient's health? Has there been a deterioration in health? Any new medication? Without all this information, we can't put a picture together of what's actually going on. And so it just looks like the Lunula hasn't worked, and that's the problem. I don't believe that to be the case. That's never the case with patients of mine. We do have cases where we have to figure it out, where we're not sure what's going on. and gradually you do get there by asking questions, by looking at footwear, by discussing with the patient where they went on holiday and what happened, and what medication they're now taking, different things that have changed. One of the biggest things that I have found with patients that affects their nails is stress. And I've had patients coming in where, it's taken us a little while to work out that actually they're really stressed at work and it's a big problem, and their immune system therefore is down. And when your immune system is down, your nails get massively affected. The same obviously when you're pregnant. We find that women who are pregnant tend to have a big problem with their nails that wasn't such a problem before. And suddenly fungus is sprouting everywhere. Nails are really regressing and deteriorating. And at that point, we stop and we wait until after the pregnancy and then we treat. But I don't really have enough information about this patient to know what's going on. But what I would say, my advice would be to debride the nails, see the patient back in 6 to 8 weeks or so, see how much they've grown, debride again if need be, leave it a couple of months before carrying out any more treatment, and then do a treatment probably once a month, and check every month before you do the next treatment whether you actually need to do it or not. Okay, we move on to another case. Okay. So I think actually this is the after picture, if those meant to be in the right order. So there should be another big toenail. Let's try that one. No, next. I'm not sure that you've got all the, I don't think you've actually got the 4 photos up there. There were 6 photos on. That's a different patient, but we can do this one. So let's, if we do this patient, so this patient was first seen in May and was last seen in September, so 4 months, had 10 treatments throughout that time, I believe. And if we look at the other photo of that big toe, you'll see the difference. There's a real difference in this one. Yeah. No, that was the photo. That one. They're the same. Okay, so there's actually been a really big improvement. The biggest improvement is that the nail has become intact and is a lot thinner than it was in the first photo. The yellow is there, but actually on the questionnaire that was sent through to me, it says that the patient has been wearing nail varnish, and whenever she wears nail varnish, it seems to regress the nails. Actually, what it's doing is it's just staining. I don't know what colour nail varnish it is, but I'm going to hazard a guess that it's a dark nail varnish with dark pigment. So what I can see here is that all the nails, whilst the big toenail isn't perfect, is actually a very normal thickness nail. It's pretty flat. It looks attached from here. The only problem is that a few of the nails look a little bit yellow. That yellow will, in all likelihood, come straight off with a nail drill. You file it down very gently and it will just come straight off, and I would expect that the nail underneath is really quite healthy. The patient needs, if they're going to be using nail varnish, to be using a base coat, ideally a light coloured nail varnish, and not keep it on for very long at all. Shouldn't be going for pedicures, should just be applying it at home. Those nails are very much improved, and I think that all they need is some routine nail care, every 2 to 3 months or so, and probably the patient will be able to manage them after a few months or 6 months or so by themselves, and that nail will continue to grow out and just needs to look after the nails. From a Lunula perspective, these nails have been healed very nicely. If you go back to the original one, Harris, just to show people, hopefully they'll be able to see the difference. Yeah, so I mean, that's a nail which isn't particularly nice to look at. It's certainly not flat. I can even see, and you can't always see from photos really if a nail is lifted, but actually you can see at the distal edge that that's really not an attached nail at all, and probably that when filed will break at the base of where the yellow is. That whole nail would just come off and break, and then the nail starts to grow through again. On the lesser nails, it's very much the sort of little white superficial stuff is probably from nail varnish. I did an experiment a little while ago. I had my nails painted and left the nail varnish on my toenails for a long time, for a good few months. I wanted to see what would happen. And of course, as it all wore off, I just had white under, well, on top of my nails. And that did eventually go. I didn't debride them, I didn't do anything like that. But if you were to take a burr to those nails, that would all come off instantly, pretty much. So yeah, that's been quite a good result there. If we go to the other foot of the same patient, Harris, and have a look and see, if you don't mind. Okay, great. So again, a few nails affected. Just a point to make with little toenails, the fifth nails, is the majority of people will have a damaged fifth nail because it presses up against shoes all the time. And so there's generally nothing we can do about that. You know, if you wear shoes which are the correct size for you, the likelihood is that the lateral border of the shoe is going to press against the fifth nail, or if that is cushioned sort of underneath the fourth, it will press on the fourth nail. If you wear shoes that are too tight, obviously that's going to be much worse. And if you wear shoes that are too big, it's going to rub anyway, because as your foot moves, it has to hit the border somehow as you're walking. So a lot of people come into my clinic and think they've got a fungal infection on their little toenail. They haven't, they've just got a damaged nail. And whilst we will often use the Lunula to sort of help that and increase the blood supply there, we won't do more than 4 treatments. We will only do the 4, and then we'll debride every couple of months or so and just keep that nail going. A lot of people tend to think that if they're coming in for Lunula treatment, that it's kind of a finite thing. You have your 4 treatments and off you go. We explain to our patients at their first appointment that that's not the case. They have their 4 treatments, and we tend to continue seeing them either by photo, or if their nails do need some nail care, we'll see them regularly. It's no different to going to the dentist, the optician, having your hair cut, being waxed, or whatever else, that it becomes part of your routine. And we tend to see people and keep the nails cut, filed, and in good condition. I have patients who come to me every 3 or 4 months, and we just do a routine nail care appointment. Takes, you know, not very long at all, 15, 20 minutes, and we just keep on top of things, and they don't have a problem anymore with the nails, even though they're still wearing the same shoes, they're still going for runs, they're still walking or whatever else. So the damage can still be there, but actually because we're taking care of the nails, they don't tend to get any further damage. But we're not doing any more than a few Lunula treatments. If you want to go to the other photo, that puts to Harris. Okay, great. So you can see that again, there's been an improvement here. On the big toenail, most of that yellow should come off quite easily. Again, I think that's pretty much down to nail varnish. On the third nail, that's a massive improvement in a fairly short amount of time. And you can see the new nail that's growing through quite nicely. What will happen is there will be a build-up on that third nail, and that will happen for several months, and you just keep on taking that down, routine nail care, and eventually you get to the stage where if there's a build-up, once you've filed that off, the nail itself looks pretty much normal. And then the next stage after that is you don't need to file it down very often at all, maybe every 3 or 4 months, but pretty much it's a normal nail most of the time. It needs to just become, it's not quite intact yet, but it will be, and it will probably look fairly similar to the second and the fourth nails that we can see there. That first nail has thinned right down. You can see a nice border that's nice and clear. That should continue to grow like that, so long as it's not abused too much with nail varnish. Okay, I think that's it for this patient. Trying to see who else we have. Okay. So you can see on this one, there's a lot of damage. There's some bruising, it looks, on the base of the big toenail. I'm not quite sure if we can we see the questionnaire and see if there's anything about trauma on there? Have you got that there? No, no questionnaire there. Okay, let's look at, so can you just go back a second, because I just want to have a look, if you don't mind. That's it. Don't click on any pictures. No, go back. I don't want to look at the pictures. I want to look at the dates, if you don't mind. Okay. So this patient was first seen 2014, I think.
16.
No, it's different patients. Okay, 2016. So it's the second, that one there. If you click on that picture for me, please. Right, and then, so you can see the bruising at the bottom there. Then if you go back and click on the picture to the left, that's it, to the left. So this is a brilliant case. That's the same patient. That's, I think one was 2016, and this, there were 9 lunulas, and this is 2017. The marks that you can see on those nails, on the right first and the left third, is bruising. There's been some trauma there. I can't obviously see a questionnaire, but there has definitely been some trauma there. And I would just let that grow out. That looks like a fantastic case. I think these are the before and afters that you sent me, actually, Harish. These weren't necessarily case studies for today. It's really good for everyone to see them. That's a really good case. You can see very clear nail there. The only problem is that there's obviously been something either dropped on the nail, or the nail has hit something on the right first and the left third, but otherwise really good. That was 9 lunulas, I believe, within a year or so. So if we go, I think all those pictures are before and after, so it's great. Yeah, let's just have a look at them. I can't really give details of when they were seen.
2014, before treatment.
Yeah, if you want to click on that one, please. and then just enlarge it a little bit so people see it's the first nail, which is obviously the problem. Now, what we tend to see with nails like this, the damage that's been done over time has obviously ruined the nail, but has shrunk the nail bed. So it's not all that likely that you end up with a normal shaped flat nail sitting on there. We use something called Builder Pedic, which is a nail reconstruction gel. And what we tend to do with cases like that is do the 4 Lunula treatments, and then at the 4th appointment, we will put a gel nail on and leave it on for 6 weeks, take it off 6 weeks later and replace it, take that off 6 weeks later, and then after doing that for 3 or 4 times, we tend to see that the nail is growing out much better and grows over that hump at the front, because you're pushing that down with the gel nail, and the nail is then being allowed to grow out with the gel and with the weight of the gel on top, and you tend to get a much better nail. If we can see the after picture, that'd be great, please. Okay, so it was the left one that we were looking at before, and you can see it's a completely different nail to what it was just before. And this was, I think, it says after the 5th Lunula. I'm not sure what the timing was in between. I know the original photo was 2016, so I don't know when. But that nail is grown out, and you can see that actually there's been a reduction in sort of the raised part of the bulbous part of the toe. It's not completely flat, and it's still quite a large toe itself, and on the right foot, but certainly a much better nail that's growing through, and hopefully that would continue to grow up pretty much like a normal nail. So very good result, and that's only with 5 treatments. I certainly think that less treatments is the way that you should all be going, rather than 11, 17, have 10 treatments that we saw before. You need to do less and let the body take care of it. That certainly works a lot more. Okay, if we go to, I think there's a 3rd before and after set on that batch. That's it, yeah. Okay, so a nail which, is certainly not intact, has very clearly been damaged. And then if we go to the after picture, I think that was, go to the after picture, let's see. I mean, that's a completely healthy nail now. From the before picture, it doesn't look like there's any evidence of fungus there, just looks like it's completely damaged nail, which I don't know the history of this patient, but it doesn't look like it's a long-standing problem. And obviously, the quicker that we catch issues with nails, the better they seem to recover. I see patients who have had damage on their nails for a few months, and I see patients who have had damage on their nails for 40 odd years. And obviously, when you have someone with such long-standing damage, the chances are you're not going to get a fully perfect nail, a fully normal looking nail. It's always going to have some damage there. And the idea, the objective is to get a healthy nail. So one that's intact. It might be thicker than normal nails. In all likelihood, it will be. It might be slightly discoloured, and you won't be able to get rid of that. But you want it to be healthy in terms of it attached to the nail bed and an intact nail. When you have a nail that's only had damage for a short amount of time, the chances are you're going to get a completely healthy, normal nail, which is great. So it's something that you need to discuss with patients at consultations. Finding out how long they've had the problem is probably your biggest clue to what to expect at the end of the day. And I think, I have set questions that I ask patients. Everyone should be filling out a medical history form first of all. to be perfectly honest, when patients fill out a medical history form, they don't always put all the information down. So I have a lot of patients over the years who put down no medication, and then when we talk through the consultation, I suddenly find out that they take aspirin every day, or they take, a steroid every day. And I say, oh, you haven't put anything down there. Oh, I didn't think you meant that kind of medication. So, patients don't often write down what we want them to write down, and you get a lot more information out of talking to them, and various clues that you get along the consultation. Finding out how long they've had the problem, how it started. So, if it was that they walked into a door and that damaged their nail, that the chances are, once you heal this damage, they're going to be careful and not walk into a door again. You shouldn't have a problem. You shouldn't have it coming back. But someone who, I don't know, does sport and continues to do sport, and they have had problems for several years because they play football every Saturday or whatever, that in all likelihood you're going to start the healing process, then it's going to get damaged again. There's no, absolutely they shouldn't stop playing sport, but they need to understand that it's going to damage their nail again and take steps to avoid that. So we do simple things like covering the nail with padded plasters or tubifoam whilst they're doing that activity to try and take some pressure off. Obviously making sure that the footwear that they're using for that activity fits as best as it can do. You have to look at the whole picture. It's not just a case of someone coming in, sticking their foot in a laser and off they go. We get some really good results, and I've seen many podiatrists around Europe certainly getting some really great results. But you have to think a little bit outside the box. You have to look at all the variables and all the factors that happen. Yeah. So are there any more, Harish? Seen all of these. I think we've certainly gone through the cases that were sent to me. I think we've been through.
Yes.
Had a look at all of these. So what I'd like to do is kind of open up if there are any questions that anyone has to ask.
Thank you, Martin. And there are a few questions.
Okay,
Just
great.
before we launch into that, thank you again for taking us through these. There's always so many points that come out of these kind of reviews, which I'm sure from the questions you're asking and from talking to you before, those of you on the webinar, that there's some really interesting learning points coming out. Apologies once again for our challenges on technology of showing pictures from Australia while we're talking about it from London. The wonders of technology, but apologies if you have to wait for pictures to come up. Martin, before we launch into the questions, one of the things, when we put the call out for cases that Harish put the call out for, we didn't really get many cases coming in that were saying that they were changing, and that's great. Obviously, there are a lot of cases, an awful lot of cases on a daily basis going on where we're getting fabulous results. We love to see those. Those of you who've got great before and afters, we always love to see those, and we've been looking at a few today. And if there are challenging cases, please put them in. Martin, I think it may be worth saying, obviously, when we put the call out for these things, we often get pictures that sometimes aren't dated, and pictures taken at different times, and not complete information on the forms. Obviously that makes it challenging for us to review a case. But also, isn't there, Martin, that there's a point here about actually good clinical practice and having these kind of records to review with the patient too, isn't there?
Absolutely. So the way that we do it in our clinic, and I'm going to just make a point that for me, I don't do things for research. People ask, oh, what's the effectiveness of the device? And I can give, figures of research that's been done. And when I speak specifically about my own clinics and the effectiveness, the answer is that every single patient that I see has an improvement. I can't tell you the absolute percentage of patients who start off with a fungal infection and end up without one because we don't take cultures. My objective is to have happy patients who are more confident about their nails. So what I do in my clinic is the photos that we take photos with before I even touch the nails. So the patient comes in, sits down, they'll fill out a medical history form, which I have a look at, and then I immediately take photos. I don't clean the feet, I don't touch the feet, I take photos. We have a label for every patient which has on it the date, what appointment it is. So is it the initial consultation? Is it a review appointment? Is it the fourth appointment? So we take photos at the first appointment and the fourth appointment. The photos we take at both of those are done, as I say, when they immediately come in. And then more photos are taken once I've debrided the nails. So I get 2 sets of photos from each appointment, before and after debriding. Obviously, if they don't need debriding, we don't take second lot of photos. We have all of those photos in a file. Each patient has their own file on a secure server on our computers. They are all labelled and dated. We can look back when patients email us photos in, we put those photos into the files as well. So what we can actually do is we can look right from the start all the way to the present day, and we have a story going on of what's happened to those nails. Now, the majority of those patients, we tend to see improvements, even if they're tiny improvements along the way. So when I ask patients to send me photos on a monthly basis, I tell the patients very categorically that I'm not looking actually at an improvement. The reason I want to see those photos is because I want to make sure that there's no problems going on. Because on a month-to-month basis, you don't see a great deal of change. But if you look at a set of photos over a 6-month period, you'll see a massive change. And I learned very early on that patients come into clinic and they say to me, yeah, I don't think it's working. My nails don't look any different. And then we look back at the photos and they say, oh my God, they were horrendous to start with. I don't remember them being that bad. And so you don't, when you look at your nails as a patient every day, you don't see, it's like looking in the mirror at your hair. You know, one day you go, oh gosh, I need a haircut. Or the day before you didn't think you did. So you don't see these tiny changes happening unless you look at the bigger picture. So you really have to have decent photos. I've now realised, and I take all our photos are all taken on a tablet. We have Samsung tablets. We take the photos, it immediately updates into the patient's file. But actually what I have realised is, you know, we've done it several different ways over the years. We used to have a proper, you know, Canon camera, we've taken it on phones, whatever. What I have worked out is that if you turn the light off when you take the photo, you get rid of all the shadows. You know, I'm certainly not a photographer, but I've learned how to take photos. So we have everyone sitting, they bend their knee, foot is flat on the bed, and you put the label so that you can see it in the photo, and you take the photo from above. If the nails are raised, I tend to take a photo from the end of the foot so that I can see on the photo that there's a gap between the nail bed and the nail plate itself. And you have to have them dated. You have to be really organised, and every patient should have their own file which has got all their photos in, you know, ideally in date order, so that you can click through them and see and get a picture, make a story of what's going on. You know, seeing photos taken in various different lights, and obviously when patients send photos into us, they're not always the best photos. You know, and a lesson I learned a long time ago, I saw some photos from a patient and I panicked and thought, oh my God, her nails got really horrendous. Asked her to come in. She came in, she sat down in the chair, and I said, hang on, your nail looks really good. What? I don't understand. And it was the light that the photo was taken in. So I now, when I receive a photo from a patient and I think, oh God, that doesn't look great, I then email the patient back and ask them what they actually think of the nail themselves. And, you know, then we have a bit of a discussion, and I know whether there's a problem or not. There's often not a problem. It's just the photo. Unfortunately, it's hard to tell in the photo sometimes what's going on. If I'm not sure, I'll ask the patient to come in pretty quickly, and we'll have a look in a minute. But photos are a good tool if patients, you don't want them to waste their time coming to clinic when you're not going to do anything. Often if a nail's progressing well and patients can cut their nails, I'm not going to be doing anything to the nail, so they don't need to come in. I sometimes have patients who are slightly older, perhaps can't take photos, don't have phones or whatever else to take photos and upload them to me. So they come in, they'll pop in for 5 minutes, I'll have a look and say they're out looking lovely, off you go. Don't charge them for that appointment. But if I'm going to be doing nail care, obviously they get charged an appointment fee.
Thank you, Martin. We've got a few questions here. So the first one, when you check in on the nail each month after the initial sessions,
Yeah.
do you laser on those sessions when you're checking in?
No, the only time I will laser is if I believe that there is a fungal infection there at that stage. So nails where the patient has come in and it's clear there's no fungal infection, in the first instance there's damage from something else, will very, very rarely have more than 4 treatments. I can't really think of a case where they do. However, patients who have presented initially with onychomycosis, then I might be carrying out more treatment if I feel that either the infection hasn't gone or they have got a new infection. And it does sometimes happen. When we see patients where the infection goes right under the proximal nail fold, the chances are you might have to do another treatment or so a little bit later on, because as the nail grows, you then see what's coming up from the matrix that you obviously couldn't see beforehand because it's under the skin and you can't see it. As a rule, no, I don't carry out extra treatments when they come in unless I feel there is a need to. And the way that I tend to assess that is when you debride nail using a nail drill, and I use a powder spray drill, which means that you've got spray there so you can take it down as far as it needs to go without friction, without heat building up and discomfort. If it breaks the nail plate very easily, and really you just go over it with the drill and you see it all crack, you know that there is live fungus there, because live fungus lifts the nail plate from the nail bed. And when that's the case, then yes, I'll carry out an extra treatment. I will see them back 1 month later, do the same if need be, or hopefully not.
Thank you. Question, is it useful to give a client a double tap, i.e. 24 minutes of treatment, which I'm presuming from this question means 24 minutes of treatment on one of the feet? Certainly that's not part of our training. It's we're limited to 12 minutes. Any comment on that, Martin?
Yeah, absolutely not. We tried it. What I believe happens is the reason that the cycle is 12 minutes is for a reason, is because that's the optimum dosage. What tends to happen if you do a second treatment straight off is you get no benefit from the second treatment. If you continue and were to do more treatment, the body actually stops doing the good that it's doing, because it sort of gets to the point where you do all these treatments and it doesn't know what's going on. So you can only get a certain amount of blood supply going down there. You can only get a certain amount of hydrogen peroxide produced by the body, and the body then stops doing it completely. So absolutely 12 minutes only. We tried it with 6 minutes, we tried it with 12, with 18, with 10 minutes. We've tried loads of different things over the years. And absolutely 12 minutes is the optimum. Please don't double dose, because it really doesn't do any good at all.
This next one is more of a comment, I think, than a question. Many ladies here in Australia have shellac nail polish, which stays on for weeks, if not months. They cover the infected nails with polish, so it's hard to get them not to wear the polish. Any comment on that?
Okay, so shellac, one of the biggest causes of nail fungus nowadays is shellac. It's really awful for the nails. I've seen several people in clinic who have come in because they have got a fungal infection. What tends to happen when the shellac is put on, not particularly well is that you get moisture underneath and you get a fungal infection, which very rapidly spreads because you can't see it and the nail is covered with the shellac. If it's on fingernails, it's actually very easy to treat, and we've had some phenomenal results with it. However, patients are advised, please don't use shellac again. And quite frankly, when they pay for an expensive laser treatment, they don't tend to go back to having shellacs. We have in our clinics antifungal nail varnish in a variety of colours. We actually get them from the States. There are various places, companies that make these nail varnishes, and we sell those to patients. I don't have a problem with people putting nail varnish on. I understand very clearly the effect that having a damaged nail has on people psychologically, and by all means put nail varnish on, but the advice given is don't leave nail varnish on for longer than a week without then giving it a good 24 hours before reapplying. Always use a base coat. Ideally use a nail varnish that does have an antifungal property, or use a base coat that at least has an antifungal property, and seal the area before putting nail varnish on top. Be very careful if going to beauty salons and nail salons, whatever. A lot of the places, particularly in the UK, are not governed, and therefore we don't know what their hygiene is like. From patients that I've seen, the hygiene in these places is particularly poor. They often cold sterilise, so I don't know, it can be that they're sticking nail files and whatever in a jug of cold water, for all I know. I don't know what they use, but I can tell you that it spreads fungus pretty quickly, whatever it is. The advice is steer clear, or take your own instruments, your own files, your own nail varnish, and whatever else, and try and keep the nails out in the open as much as possible, and nail varnish free if possible. But we have to be realistic. If you've got nails that you don't like, you're going to want to cover them up. I tend to think that lighter nail varnish is much better than darker nail varnish for two reasons. First of all, the less pigment in there, the less it can stain your nails. And also, when it's lighter, it doesn't tend to show up all the lumps and bumps and ridges on nails. Darker nail varnish does tend to show that up, even though you'd think it'd be the other way around. So, yeah.
And next question, is there a test available that confirms it's a fungal nail? Well, of course there is, and you've spoken during today, Martine, about the fact that you don't use that, and they are perhaps of questionable accuracy. A quick comment on that?
So, yeah, there are various things, actually. There's, your standard cultures that you can send off to a lab. There's in-trays, which you obviously take a sample, put it on the in-tray, and you leave it in a cupboard for a couple of weeks, and it grows a culture. There's something called a 5-minute test now, which I personally haven't used as yet, although I might do just to see. But actually, if you're using the Lunula, there is no need to find out whether there's fungus there or not, because by virtue of the fact that the device has the 405 nanometer beam, if there's fungus there, it should treat it. And by virtue of the fact that the device has the 635 nanometer there, if there's not fungus there, it should still heal the area anyway. So there's kind of no need. We used to take cultures when we used the pinpoint, because the hot lasers only have one function. They heat up fungus till it dies. And if there isn't fungus there, all you're doing is heating up other tissue, and potentially burning it. So it was much more important for us to take cultures there. Generally, samples have a 30% false negative rate because A, there isn't often live fungus on the nail plate itself, and we don't biopsy nail bed because that causes more damage than anything else. So, yeah, we don't take cultures now unless a patient specifically asks, but very few of them would want a culture because there's no need, because the device actually helps whether there's presence of fungus or not. And it also doesn't matter what type of fungus it is, if it's candida, dermatophytes, or anything else, it tends to have the same effect, and we carry out the treatment by the same protocol, whatever the problem is.
Great. Martin, you mentioned during the webinar the name of a gel nail that you use, and somebody's asking for that name again.
Okay, it's Wilde Pedie. That's WILDE hyphen PEDIQE. It's actually a German company. They have training centres all around the world. I don't know if there are any in Australia. There may well be. There's a training centre, might actually be 2 training centres in the UK. Do a day's training, and it teaches you. It's essentially very similar to the gel nails that are put on in beauty salons, but it has. I tend to use they have silver in some of their gels, so that acts as an antifungal. So I would use that first on the nail, and then I use either natural beige or cool pink, so it sort of blend in with the skin, and then you can paint those nails. Personally, I don't paint people's nails. I don't think anyone would trust me to paint their nails, but people can go and paint their own nails. And what you've done is you have created a nail or gel on top of their nail, which has sealed the area so that they can paint it, and we leave it on. The companies say you can leave it on for 3 months. I disagree with that. I think because nails grow, what tends to happen is it lifts after a while. So we don't leave it on for any longer than 6 weeks. And then it can be replaced straight away after doing it a few times. So, I tend to say to patients that if they can leave it off, it's always better to have your nail out in the open. But what we find with it is that nails that are not adhered to the nail bed, when you use the Pedie gel, it tends to help push it down. It's a really good product.
Thank you. We've got 4 more questions. Excuse me. Would you suggest treating both feet in one session so that it's not passed from one foot to the other? Certainly in our training, we always advise that you treat both feet. So to keep this a simple question, Martine, is there ever a case where you would only treat one foot?
Honestly, yeah, I only treat one foot in a lot of cases, actually. If someone has come in and there has been no spread of infection, so it's just one nail affected, yeah, absolutely, we can treat one foot. Fungal infections only spread if there is a way of it getting into the nail. What we tend to find is with one foot, one foot is generally bigger than another foot. You tend to get damage on one foot on the nails and not on the other. Look, it would always be great to treat both feet, but not every patient wants both feet treated. We give our patients antifungal cream to use after treatment, after the first laser treatment until they finish the tubes. I always suggest that they put it on both feet anyway, in case there are spores sitting on the other foot. And we keep an eye on the non-affected foot, throughout the course of treatment anyway. We have different prices for treating one foot and both feet. Our price for treating both feet is not double treating one foot, it's only a tiny bit more. So actually it encourages people to have both feet treated, but some people don't want to. So, it's better. I don't think that there is that much cross-infection, perhaps not quite as much as we originally thought, because once people are educated, they're slightly more careful. So, you tend to have damage in the other nails. And if those nails are not looking at all damaged and the patient's had an infection for a long time and it hasn't spread at all, it's safe to treat one foot. James, you there?
Sorry, did you? I think we may have lost it temporarily there. The next question is, do you recommend using urea 40% to soften the nail prior to debridement and during debridement?
I don't use it. I know people who do. I never have done. I think if you've got a decent nail drill and your debriding skills are good, you shouldn't need to. I use a variety of burrs of different sizes and different coarseness. Yeah, I don't use it. I think that maybe if you use it initially and you get all the rubbish off, all the debris off, maybe that help. But actually, I don't know is the answer. I don't think you want to be softening and putting moisture into an area where there's fungus. But you know, the answer is I can't categorically tell you because I have never used it. So I know people do and they're happy to. I don't.
Thank you. Do you augment treatment with antifungal sprays, creams, or tea tree oil?
So yeah, we use cream actually. In the UK, you can't get antifungal sprays, liquid sprays that are bigger than a few millilitres. So we did used to give out Lamisil spray, but it only lasted about 2 days because they're really tiny pots. In the US, you can get much larger ones. I like sprays. I think they're really easy for people. I don't like powders because it clogs up pores, so only liquid spray. But because we can't get a decent enough size here, we give out spinafine cream and we also give out clotrimazole cream. We apply it to the patient after the first treatment so they can see how to apply it. We do it ankle down, all over the foot, in between the toes, under the arch, absolutely everywhere. Only a thin layer, rub it in properly, ask the patient to do it once or twice a day. And the reason I say once or twice, if they don't have any evidence of tinea pedis, so of athlete's foot, really they can just do it once a day. If they do have tinea pedis, we ask them to do it twice a day. The reason that we give terbinafine and clotrimazole is because clotrimazole treats candida, treats yeast. Terbinafine treats dermatophytes. Sometimes it's very obvious what type of infection it is. So if it's very yellow, it's dermatophytes. If it's very white, it's yeast. But at other times you can't tell, particularly if it's a long-standing infection. So we give both creams to cover all bases.
Thanks. And just one more question came in. Actually, there's 2 more questions left, and then we really must wrap up today. This question we kind of really handled a little bit. Is there any risk with double treatments of laser in one consultation? Well, you've talked about the fact that it's certainly not effective to do a double treatment on one foot. Is there any risk? Well, low-level laser is generally very safe, but we just wouldn't advise doing double treatments of it.
Yeah, I don't think anything bad's going to happen, but nothing good is going to happen either. So why would you do it? It's a waste of time.
Thank you. And finally, then, how do you recommend Lunula laser to your patients? What is your spiel to the patient? any parting comments for you, Martine, about how you position the laser treatment and how you describe it?
Okay, so essentially, in a very quick nutshell, rather than a 40-minute consultation, you know, I've been a podiatrist for a long time. I can categorically state that for the first 10 years of my career in the National Health Service, I didn't help anyone get rid of their fungal infection because we were totally limited in what we could do. We could either ask the doctors to prescribe systemic medication, or we could ask the patient to apply an antifungal topical treatment. You know, I've seen patients who have tried everything, and categorically the thing that works the best is the Lunula. It doesn't have side effects. It is a painless treatment. That tends to be the biggest plus point for it, having used a treatment on patients that's not painless. Research done on it has been incredibly effective. You know, I've treated thousands of patients, and pretty much every patient has had an improvement in their nails. We haven't always had fully successful cases, but we work very hard to get, achieve success in all our patients, and we get them in probably nearly 100% of them. It may take time and patience, but we do get there. I run a business solely on the use of Lunula treatment. I don't use anything else. I think that pretty much speaks for itself that, having used it for 6.5 years, we're really successful in what we do. We have very happy patients. I don't think I need to sell it any more than that.
Thank you, Martine. That brings us to the end of today's webinar. And Martine, thank you very much again for sharing your experience and wisdom with us, and I'm sure there's been a lot of key learning points that came out today for everybody. So thank you very much. Thank you to Harish Mitra, our Australian New Zealand distributor, for putting out the call, for hosting us today, and putting out the call for the case studies there. And thank you to all of those of you who've dialed into the webinar and submitted your case studies, those of you who submitted the case studies, and your questions online. Of course, I hope you found today useful. So thanks again. Have a wonderful rest of your evening. And that's it from us. So we're signing. Thank you very much.
Thank you.